And thank you so much for joining us today for today's webinar. As Mel has said, we're going to be talking about deep brain stimulation, what, when, why, and how. I'm Dr. Sonia Mather. I'm a family physician, as was mentioned. I'm also a Parkinson's patient for the last 21 years and have the pleasure of being a member of the board of directors for the foundation as well. And I have the pleasure of being your moderator today. So unfortunately, as you're all well aware, there currently is no cure for Parkinson's disease. So our medical management and any lifestyle changes that we make really have to be devoted to improving quality of life, managing our symptoms, minimizing our side effects, and there are a whole vast array of treatment options that are available to us. No two people really have the same treatment regimen. We seem to be as varied as our presentations and our prognosis and our symptoms are in terms of our treatment. But along with the medical management, there's also a lot of surgical options, or there are a couple of surgical options of which deep brain stimulation, or DBS, is the most common. And we're very fortunate that Dr. Kara Beasley has the time to discuss some of the information around DBS and how we can make decisions about that in our management, in our care. Welcome, Dr. Beasley.
Thank you. It's my favorite thing in the world to talk about, so.
So Dr. Beasley, I think many of our listeners have heard about DBS and know it involves some sort of surgical procedure, but might not really know exactly what it is. So could you please start by explaining what is deep brain stimulation?
Absolutely. If we could see slide number 3, that'd be great. So you can think of deep brain stimulation as a pacemaker for the brain. So essentially what we do is we take a wire, or also known as an electrode, we implant it deep in the brain in one of two structures, either the STN, subthalamic nucleus, or GPI, globus pallidus internus, and then that wire travels through a small hole in the skull, connected to a wire that runs down to the chest wall with a battery, also known as an IPG, or internal pulse generator, that goes in the chest wall, either on one or both sides, depending on surgeon preference and some other technical respects. Essentially, what we do is provide high frequency electrical stimulation to these deep structures, and it overrides the abnormal activity that's going on in the circuit, the movement circuit, to bring motor controlling circuits into a more normal state of function, so to normalize. And it reduces the movement disorder symptoms. So very specifically, it will treat tremor, stiffness, and slowness, or so tremor, rigidity, and then bradykinesia is our fancy term for slowness. Those are the cardinal symptoms of Parkinson's, and that is what deep brain stimulation is expected to treat.
Now, we did have one question from a listener ahead of time, and they were wondering, which of those targets would you say would be recommended for dystonia, for instance?
So the better target for dystonia is going to be the globus pallidus internus, or GPI. Both of the targets treat tremor, rigidity, and bradykinesia. However, dystonia tends to respond slightly better at the GPI target. However, you can get responsive dystonia with the STN target as well.
Okay. And is there any other differences between the two targets that you?
There is. So data shows us that implantation in the STN target can allow a person with Parkinson's to decrease their medication after surgery on average by about 50%. Whereas for GPI, that medication reduction doesn't tend to occur. So for instance, if somebody is experiencing a lot of medication-related dyskinesia, we would elect to move towards the STN target with the goal of being able to cut meds by, on average, about 50%. The other difference is in the cognitive function. So STN tends to be a little bit harsher cognitively than GPI does. So in patients who are sort of riding the edge of a cognitive dysfunction or dementia, but are still considered candidates, GPI may be a better target than STN to preserve cognitive function in folks with Parkinson's.
Great. I think we'll get more into those potential issues as well later on in the webinar. Did you want to continue with telling us a little bit more about the sort of, I guess, mechanical?
Yeah. There are some new and interesting developments just in the last year in deep brain stimulation. So if we could go to slide number 2, I'll talk a little bit about the components of the system. I'm sorry, slide number 4. I apologize. Slide 4, the components, the first component is the lead. That's the part that is implanted in the brain. Traditionally, for the last 20 plus years, there was only a traditional ring type lead. And what that means is those little metal contacts that you can see on the picture here would provide stimulation in a circle around that lead. Increasing energy or jacking up the voltage would increase the size of the field. And in this situation, placement is very critical. These are deep, small structures in the brain. And so if you have to turn up the energy so much, you can get bleed over into other structures causing side effect. If you advance to the next slide, just in the last year, we've had an FDA approval of an advancement called a directional lead. There are 2 companies on the market, Abbott and Boston Scientific, and they have very similar construct of the leads, although and both leads are pictured here. The larger picture is the Boston Scientific lead, and what this allows is, as you can see, instead of a ring in the 2 middle contacts, there's separation. So there's actually 3 little metal contacts instead of a round circle. So that would allow us to turn on stimulation or electricity to just 1 or 2 of those contacts in order to drive stimulation to a different part of the brain. If you advance to slide number 6, I can show you what I'm talking about. So our goal is to accurately target therapy and avoid the unwanted side effects. So as you can see, the blue circle represents where the electricity would be placed. And so that's with a traditional ring. You just get a circle, and the purple is where we would like the stimulation to be. However, the blue circle covers some areas that would cause some side effects. If you advance to the next slide, it shows a directional lead. So it shows the directional lead placed in the STN nucleus with only 2 of the contacts presenting electricity. So now we're able to, instead of having a circle, we're able to shape that field and drive stimulation away from side effect areas while capturing stimulation in the structure of the brain that will actually affect Parkinson's. So it gives an overall better efficacy.
And could you maybe just go over some of those side effects that you're trying to avoid with the directional lead?
Sure. So just lateral, or just to the outside of the STN nucleus in this case, is going to be the capsule, the internal capsule. That part of the brain controls muscle movement. And so people who get stimulation in this area may feel a tightness, a pulling, or even a muscular contraction if this part of the brain is stimulated. More medially and deeper, we have some of the eye motion portions of the brain. So people can get eye deviation. People can get tingling, tightness, pulling. Sometimes people in the more anterior or frontal portion can get a feeling of dis-ease. It's a very nebulous feeling, but it's just like, I just don't feel like things are quite right, or some anxiety or anxiousness. So the more accurately we can apply electrical stimulation only to the parts of the brain that we're trying to stimulate, the better off people will be. And as Parkinson's progresses and stimulation needs to be increased to capture symptoms, it allows for a better therapeutic window than the traditional ring style or spherical style stimulation. So this is a huge advance in deep brain stimulation for Parkinson's, and one that we're very excited about.
And is this available now?
It is. It is FDA approved in the United States. I believe it is FDA approved in Canada, or not FDA, there's no FDA, but approved in Canada as well. It is. Both of these companies have leads approved.
Like precision medicine, where you're taking the patient and maybe sort of seeing what symptoms they have that sort of bother them the most, and then directing the electrical current towards those areas specifically. Is that a fair assumption?
That is a fair assumption. The other thing it allows us to do is refine it very specific to where a lead is placed. So sometimes a lead is not optimally placed, and it really allows us to salvage a lead that is not exactly precise. When we're talking about how precise this is, we're trying to stimulate a target that's approximately 4 millimeters by 6 millimeters in the shape of an almond deep in the brain. So that's exceedingly precise. So, and every brain is different. And so just a slight 0.5 millimeter move one way or the other could be optimal versus non-optimal. So in a situation in which it's perhaps not a perfectly optimized lead from a surgical placement, you can still salvage things without having to replace the lead or go through another brain surgery.
Right.
And then as things advance, you can really be very, very precise. So it's exciting technology and a huge advancement.
Excellent. There was one question that a listener had about closed loop DBS and what that is, and should they wait for it to be approved?
So closed loop is not FDA approved, but the idea is that right now, all we do is send electricity to the brain. And we change that electrical amount, as I've explained, based upon what symptoms, what side effects, how effective stimulation is. Closed loop would actually sense the electrical band in the brain and turn off and on depending on whether or not that circuit is out of alignment. Is the simplest way that I can think of stating it. And so it can allow us to turn off and on stimulation based upon what's actually electrically going on in the brain. So it too is exciting and interesting. We're learning a lot about how this movement circuit occurs and what goes on there in folks with Parkinson's. Is it worth waiting? I would say that the answer to that is probably no. And the reason for that is there is a window. So if we could advance to slide number 12, since we're on this topic, there's a window for candidacy. Now I'm going to stay straight up, and this is a timely, the window photograph I picked when I sent these slides out last week happens to be one of the windows of Notre Dame, one of my favorite windows. So I apologize if that anybody recognizes that was untoward. But however, the window is that we treat typical Parkinson's, and the window is that you have to still respond to your medication. So we do this on-off testing where we take patients and we bring them in off of all medication, and we run the motor section of the Parkinson's rating scale, ask them to take their medication, and then wait about an hour so that it starts working. And we want to see about a 30% reduction in their rigidity and their rigidity and their slowness. Tremor, it doesn't really matter to us whether or not tremor responds, because this simply works for tremor. So we like to see people who get a response from their medication. If you're no longer getting a response from your medication, you're less likely to get a response from deep brain stimulation. The other piece of the window is dementia. And only about 10% of Parkinson's patients develop dementia. But if you are someone who is starting to develop cognitive decline, there is a point at which deep brain stimulation is no longer safe for you. And so that window is very important. So when we evaluate people for deep brain stimulation, we do that on-off testing, and then we do neuropsychological testing, looking very specifically for that cognitive decline, because if you have frank dementia, we can actually make you worse. And that's not what this surgery is about. So waiting for a newer technology to come out, in my mind, doesn't make sense in this situation, because you might fall outside of that window at a certain point.
Great. I mean, that sort of brings us back to when is the appropriate time for a patient to proceed with this type of intervention? At what point do patients move forward in their treatment regimen to include a surgical treatment?
Perfect. If we could see slide 11, that slide, we talk about the cardinal symptoms of Parkinson's are tremor, rigidity or stiffness, bradykinesia, also known as slowness. So as Parkinson's progresses, medications can fail to provide consistent symptom control, so that you can either get wearing off, meaning you might take the medication and one time it works 3 hours and one time it doesn't work at all. And it becomes very unpredictable, or it can have side effects, motor complications such as dyskinesias. Some of the medications can cause hallucinations and cognitive difficulties. Some medications simply aren't, some patients and people simply can't tolerate the medication. It can cause nausea, it can cause low blood pressure or other symptoms, and so they can't tolerate medication. So when the optimal time would be when medication starts to become a little less predictable, or you're having to start to escalate the medication dose, or you have some troubling motor symptoms such as wearing off, dyskinesias, fluctuations. And then if you have refractory tremor, meaning you take the medication and your tremor does not go away and you're simply shaking, any time is a good time. But what we want to avoid is folks who, I'm going to wait till the very end, till medication no longer works for me, because that may be when you fall into that window. What we do know is, we used to say you had to have Parkinson's or symptoms of Parkinson's for at least 4 to 5 years prior to implantation. There's some newer research out that shows that it may be safer earlier. There was a large trial in Europe and also a trial out of Vanderbilt that shows that it may be safer to do deep brain stimulation earlier in the diagnosis, within a couple of years of diagnosis, when that medication is just starting to wear off. And so we're doing more studies to see what the effects of that might be, but we don't really say hard and fast, you have to have had Parkinson's for 4 or 5 years any longer.
Now, you said that it would be safer to do DBS earlier, according to those studies as it stands now. Would it be more effective at that point as well? Is it better from an effectiveness point of view, or just a safety point of view? Or do we not know the answer?
We seem to find that patients, the early STIM trial out of Europe showed that patients who had deep brain stimulation a couple of years earlier had better overall quality of life and physical and bodily discomfort. And we do know that deep brain stimulation is effective for quality of life. And we do know that it is effective for overall bodily discomfort, medication usage, stigma, social symptoms. As a matter of fact, my favorite slide, if you want to pull that data up, is number 17, showing the quality of life data. And so my philosophy is that once you have a solid diagnosis of Parkinson's, and if you look at this slide, everything above the line is an improvement. Everything below the line is a worsening. And deep brain stimulation is that dark teal color, and medication is that light blue color. So you can see across the board for every single quality of life measure, deep brain stimulation improved. And only for 2 quality of life measures, bodily discomfort and social support, did medication alone improve on a quality of life scale. And so from my perspective, if it helps reduce medication, if it helps you live better with a better quality of life, and there is some data that shows that you live longer, morbidity and mortality is lower, then waiting makes absolutely no sense. I just kind of think, why would you want to wait to feel better and to live better?
Right. Well, and that's I like that graph as well, and I can see why you like it. And certainly it does show that improvement in quality of life. Now, we know that DBS sort of targets the motor symptoms of the disease, as you mentioned. But we also know that non-motor Parkinson's symptoms, such as mood disorders and sleep disorders, pain, et cetera, can really adversely affect quality of life as well for patients. So which symptoms remain challenging and don't seem to respond to DBS?
Unfortunately, balance tends to be one complaint or a symptom that folks struggle with, and balance does not improve with deep brain stimulation. Cognitive symptoms do not improve. Depression is another one, and that not only doesn't improve, but in certain cases can worsen. And there have been, to be very open, cases of worsening depression and suicide with deep brain stimulation. Now, if we're getting really technical, that tends to be when somebody has stimulation using that bottom electrode that's stimulating another part of the brain. So the neuropsychological evaluation that I talked about also looks for depression and anxiety, so that we can be very aware in folks who might have that as a part of their Parkinson's symptoms, and pay attention to that and avoid that deeper contact, or get some psychiatric support. The other things that don't get better are things such as salivation, constipation, softening of voice. Those all tend to be to be symptoms that just remain troublesome and can be treated in other ways with big and loud therapy and other physical therapy, but just not for deep brain stimulation. And in my opinion, as a bioethicist, it's very, very, very important that you sit down and have a real conversation with your provider, both your surgeon and your neurologist, talking about what your expectations are. Because if you have an expectation of a symptom improving that won't improve, then even if you get better from your tremor and all of these other things, somebody may still be very disappointed and unhappy with their surgery. And so it's exceedingly important that everyone is clear on what should improve, what shouldn't improve, and what your goals are as a person living with Parkinson's before you undertake a surgery, even though it's a low-risk surgery before you undertake a surgery.
Now, some of this may be review, but I think it would be really interesting and helpful if you could just maybe go through the criteria that you kind of look for in a patient that comes into your office when they're asking about deep brain stimulation. What are some of the questions that you ask of them?
So I want to know how long they've had Parkinson's. I want to know, I want that on-off score. I want to make sure that they are getting better from their medication. I want to know what troubling side effects they may have with their medication, and if they've even tried medication. Sometimes people show up to my office and they've not even tried medication because they know I'm a Parkinson's expert. And I say, no, it's time to go away, and let me give you the name of a great movement disorder neurologist that you can talk to. I also ask about the depression issue and the cognition issue, and we do that full neuropsychological evaluation. And then I sit down and I really say, and here's my key question, tell me what you cannot do today that you want to be able to do after surgery. What is your goal for surgery?
Right.
And if that goal is, for instance, I want my balance to be better, we have to have a really clear conversation that balance isn't going to get better, right, and really tease out what matters. Because yes, I can put a wire in the brain, that's very easy, but I want to make sure as your surgeon that everybody's going to be happy at the end of the day.
Absolutely. One of the listeners was wondering about freezing of gait. Does that seem to improve with DBS?
It can or it can't. So if you freeze because of medication, meaning if you take your medication and then that seems to make you freeze, then perhaps cutting medication would make things better. Some freezing of gait can improve with deep brain stimulation. It's just not one of those that we say absolutely freezing of gait will get better. It really depends on what's the cause. It's almost like dyskinesia. If you have dyskinesia from your Parkinson's itself, which some folks do, then that may not improve. If you have dyskinesia with medication, then cutting medications, it may improve. So freezing of gait is a plus minus sort of depending on what the real underlying cause of that freezing is. But yes, it can improve and oftentimes does.
And there's one slide you have, I think, talking about on times and off times with dyskinesia, without dyskinesia, in terms of improvement with DBS. I think it's slide 16.
Yeah, could we pull up slide 16? So this is data on time. So just to be clear, on time means when you're feeling your best with tremor or with symptom relief from medications, and off time means no relief of symptoms. And so what we can see is before surgery, which is on the sort of left-hand side of your screen, there was a 49% of the day was spent on with dyskinesias, 27% was spent on without dyskinesias. So really the effective part of the day where there's no dyskinesias and everything's working great was only 27% of the day in about, this is a study in about 100 patients. They then performed surgery on those patients and their day went from 27% to 74% of their day without dyskinesias on and responding to medication. Also, they also went from 23% of no response whatsoever down to 7%. And so what you really see is, gosh, if I had another, 27 to 74% of my day, that big of a change of my day where I'm more effective, feeling better, able to move better, just overall feeling my best, what a change that would make. In I don't have Parkinson's, it would make a change in my life.
No, it's a huge amount of improvement in quality of life. And that would sort of translate into so much more productivity and ability for patients with Parkinson's. That's really remarkable. So I guess we sort of learned about some of the benefits and the types of patients that you look for DBS, but maybe we'll get into some of the logistical side of things and sort of the how, I guess, of this webinar, if you want to talk a little bit about that.
Sure. So there's really two basic approaches to surgery, and that would be the first decision is frame-based, so it would be slide 20. So there are frame-based or frameless. And what does that mean? It means we have to find a way to get inside of the brain very, very accurately to less than 0.5 millimeter of accuracy some way. So the picture on the far left with that big, large halo thing, that's called a Lexell frame. That's one of 2 frames that are traditionally used. And that's the traditional way. It allows us to use Cartesian geometry to get from the outside to the inside at the right angle, missing all of the vessels and catching as much of these structures as we can. The other 2 images are 2 examples of frameless. The only difference between the 2, technically they're all frames in my mind. They're all screwed to the skull, but with the frame on the left-hand side, the big one, your head is also then affixed to the table so that it cannot move. Ultimately, it comes down to frame versus frameless is the surgeon's preference. And so some surgeons trained on a frame, they understand the frame, the left-sided picture, and that's how they find their surgery is the most accurate. Other surgeons use the frameless approach. It really is surgeon preference. To be honest with you, I have done both framed and frameless. And when I asked my patients afterwards, how bad was the frame, how bad was the frameless, they really had no preference. So I would honestly, if I were you, leave it up to the surgeon to do what they are most comfortable with, because being accurate is very important. If you advance to the next slide, the next question is awake versus asleep deep brain stimulation. There's a lot of data coming out, and so this is a picture of surgery for asleep deep brain stimulation, and then some of the planning software that we use to get to the outside of the brain, to the inside of the brain. There is new data coming out about asleep versus awake surgery. Traditionally, we did the surgery awake, and what we mean by that is we make you so sleepy that you're snoring, place our frame somehow, drill our hole, and then get to the part of the brain. The brain has no pain sensors. So once you have all of that open, the pain is done, then you wake people up. The advantage to awake surgery is that you can actually perform what we would call microelectrode recording. You can listen to single cells or cell groups in the brain all the way down. You can hear when you get to the exact right target, and then you can actually test. So we move people's arms around, we watch their tremor go away, we move their legs around, we ask them what side effects they're experiencing when we turn on the stimulation, so that we know that when we leave the operating room, it's exactly where we want it to be. And if it's not quite where we want it to be, we can make that move ahead of time. Asleep surgery, traditionally, early on, did not allow for that. It was simply taking the target and having the lead meet where you wanted the target to be. If in that 20 to 30% of folks, the target wasn't exactly in the right spot, you might end up with a suboptimally placed lead. We're now becoming better and better and better at listening to the brain, even though a person is asleep. And so there's a lot of data out that shows asleep surgery can be as accurate and as effective as awake. Every surgeon has their bias. My personal bias is awake surgery. It's really very well tolerated. I actually had a patient yesterday who said, wow, that was kind of fun. Now that seems crazy, but they were listening to their brain. They were like trying it out and watching it make things better. So it sounds very scary, awake surgery does, but it actually is very well tolerated. And for that guy, at least, was very interesting to experience. So again, you can have a conversation with your surgeons. Some surgeons only do asleep, some surgeons only do awake. But at the end of the day, what you want to be is the most accurate possible. So my recommendation is that you have surgery with a fellowship trained functional neurosurgeon. That's somebody who spent an extra year to 2 years after their neurosurgery residency, that's 6 to 8 years, doing nothing but stimulation, because really the technical part of the surgery is the knowledge of where to go, how to get there. not really performing the surgery. And those folks have extensive training in how to get there. They spent 2 years or a year doing nothing but that. So ultimately it's a discussion and it's a decision. And everybody has their biases. Some people say I would never have surgery awake because it just freaks me out. Some people are like, well, why wouldn't I have the awake surgery if you can test it out and I know when I leave, I'm confident when I leave. And so there's not a right answer, but those are the two different, and there's a lot of debate. I go to conferences and the asleep people are fighting with the awake people and not fighting, but discussing.
But is that awake and sleep decision, can that be left to the patient or is it very much surgeon dependent? Can most surgeons do both is what I mean, or?
No, so it is very much surgeon dependent. It takes a lot of equipment to do this surgery, and there are some surgical centers that simply do not have the extra equipment it would take to do a sleep. So if you really want a sleep surgery, you should seek out a surgeon who does a sleep or can offer that, and they'll tell you. So for instance, I do most of mine awake. But if I had somebody who had to be asleep and I didn't have the technology and they really wanted to be asleep, I would refer them to a colleague. I have no problem with that. So it depends on the surgeon and what technology they have available to them or equipment they have available at their facility.
Right. How long does this whole thing take? How long does the surgery last usually?
So it used to take hours and hours and hours. Most surgeons can now do a single side within an hour. There's some setup, et cetera, but the actual surgical time, my typical time frame in an awake surgery with testing even is from cutting the skin to closing and everything is about an hour to an hour and 15 minutes. So we're no longer looking at, they might spend 3 or 4 hours in the operating room getting set up and getting anesthesia, et cetera, but the actual surgical time, most surgeons have it down to an hour to 2 hours at most.
Well, for one-sided surgery.
For one side. And then there are some folks who do it asleep that they can do asleep both sides in an hour and a half to 2 hours.
And how does one make that decision whether it's one side or two side?
That's really a philosophy. I tend to do one side at a time because you get a little bit of air inside of the skull when you open it. And so then the second side becomes a little bit more difficult. I also tend to do one side at a time because cognitively, after surgery, patients tolerate it better. Mm-hmm. So my personal bias, and every surgeon is different. Some surgeons do both at the same time, some stage and wait a month in between, some wait only a week or two in between. It really is, medicine's an art for a reason, but that would be some of the reasoning why you might wait. And definitely if there's cognitive decline and somebody's riding the edge of that window, you probably want to wait about a month in between placing the sides because we do have data that shows that's gentler on cognition.
Okay, that's really good to know. Now there's risks with any surgical procedure. What are some of the risks with DBS?
Sure, risks include bleeding, and that can be bleeding deep in the brain. That's a very low risk, about a 1% to 2% risk, depends on the literature you look at. But even among those, large hemorrhages or strokes are few and far between. Mm-hmm. Infection, there's about up to, depending on the study you read, up to about a 7 to 10% infection rate. I usually quote about 3 to 5%. Infection, it's typically at the generator site, but occasionally can travel to the brain. If it gets infected, it needs to be removed and treated. The wires. I'm sorry?
Can it be replaced then again? Can someone have it after an infection, another DBS surgery?
Yes, they could. It could be replaced. Other risks to surgery are that it's not in the right place, either awake or asleep, that it's not quite in the right place, or that it breaks or moves at some point during the life of the device. And if that occurs, it has to be repaired or replaced. Right. If it's not in the right place, it needs to be replaced and put in the right place to be efficacious. Other risks of the surgery, a lot of them are associated with the stimulation side effects, and with these newer directional leads that are very exciting, we can mitigate some of that without moving a lead, without having to go back and redo the surgery. So that's one of the reasons we're super excited about that technology.
That's excellent. It's a lot easier that way, for sure, I'm sure.
Yes.
What about the patient stay in hospital? How long is that usually? Like, what's their postoperative course like?
My patients, after the brain procedure, go home the next day.
Oh.
Yeah, next day. And then when they go for their generator procedure, which the generator procedure is a separate procedure where you open over the back of the wire and then tunnel down to the battery in the chest wall, they go home same day. So, and then once that's all connected, then they can go to their programmer, and their programmer can then start programming. They could literally start programming the day of surgery for the battery, although we tend to wait and let people recover from their anesthesia and such before we do programming.
And I think we have a picture of some of the hardware, maybe the batteries, I think, slide 8.
Yes, slide 8 shows the generator. It has all 3 companies available. Yes. So the one on the left is Boston Scientific, and there are 2 generators available. One is a rechargeable, one is a non-rechargeable, and then the programming device. The smaller item you see there is the patient-held programmer, and then the larger tablet is the physician programmer. The one in the middle is Medtronic, and this particular one is a non-rechargeable. However, there is a rechargeable option. The purple is the physician programmer, and the smaller black is the patient controller. And the far right is the Abbott system, and so that's the Abbott generator. Theirs is their patient programmer is on an iPod, and then the physician programmer is the larger one. Which brings me to the patient control. There are some folks who are very technologically facile and very good at technology, and they have a big window, and so their programmer, whether it's the neurologist, typically the neurologist, would say, hey, I'll let you turn this up and turn it down and play around with it a little bit. There are other folks where it's just a set it and forget it and leave it alone, and we don't want to play around with it. What the patient controller does allow is for you to turn it on, turn it off, check the battery so that you can know. And so you get taught how to use all of that when you have this implanted. So each one of them has a patient controller, a physician controller, and then the battery.
And one of our listeners wants to know, how long does a non-rechargeable battery last before it has to be replaced?
Depends on the amount of energy you're using, but typically about 3 to 5 years. Although some of the newer, as generators become better and better, we're getting longer and longer generator life. And then the rechargeables are anywhere between 7 to 15 years, depending on the company.
That they would have to be replaced?
Replaced. And replacement of those generators is, I kind of joke, if I could install a zipper, I would, but it's really a 10 or 15 minute procedure where you come in under local anesthesia, you reopen the incision, pop the battery out, plug it in, pop it back in, and sew it up. So I really, if I could install a zipper, I would, jokingly, but it's true. So replacement with rechargeable generators, the replacement times are much better. So if people like rechargeable and can tolerate recharging, and it really depends on how much energy you're using and all of those things, how often you have to recharge, it can be better for you, because you don't have to have surgery every 3 to 5 years, might only be every 15 years or every 10.
Do you have to go in to get it recharged, or is that something you can do at home?
That's something you do at home. Each has a recharging system that sits over your shoulders and over the generator and just recharges while you're watching television or reading the paper or whatever you might like.
That's really great. There were a couple of other questions, if you don't mind, about DBS in comparison to other treatments. Mm-hmm. One of our listeners wanted to know, what are the pros and cons of Duopa versus DBS?
Well, so the pros and cons are that, so deep brain stimulation provides electrical stimulation. Duopa is the gastrointestinal pump. Mm-hmm. So that pump goes into the stomach or into the GI system via external PEG tube. So that everything is external connected to an internal. And so there can be increased rates of infection. There can be increased rates of complications of such. And so you have this pump that you hold and you wear or you wear over a bag or such. And so you're connected to something externally. So in my mind, the pro of a DBS or deep brain stimulation is that it's all internal. Once it's implanted, it's all under the skin. Yeah, you carry your charger with you, or your charger or your handheld with you, but you don't have anything external. So, and there's lower rates of infection and such. But that to me, in my mind, is the bottom line of the pros and cons.
Yeah, that makes total sense. And there's another question about DBS in comparison to the potential for stem cell treatment.
Right.
And can they have the DBS reversed and stem cell treatment in place?
The other beautiful thing about deep brain stimulation is if we get something like stem cell approved, which it's not at this point in time, but if such a thing occurs, it's completely reversible. You can have it surgically removed and you can have something else done. So it is a benefit in that way, as opposed to things like thalamotomy, where we radiosurgically or with ultrasound burn a hole in the brain. Well, you can't take a hole out. You can't fill a hole in, but you can certainly remove deep brain stimulation and do something different. So currently we don't have stem cell, but if that were to be a therapy in the future, certainly you could have your deep brain stimulation removed.
So it doesn't preclude you from future possible developments, really?
Doesn't really, no.
That's really good to know, actually. A few other inquiries about who benefits from this procedure. This listener wanted to know what ratio of individuals are not helped by having the DBS procedure? What is the failure rate?
So there's not really a failure rate per se. We don't implant deep brain stimulation in patients who don't meet our criteria, so don't fall in that window. If you fall in that window, you can expect an improvement. It's different for every person, but you can expect improvement. Where I would say there's a failure rate is when somebody's implanted inappropriately. So they're implanted outside of that window, medication no longer works, and they have cognitive decline, and that would be a failure, but that's a decision-making failure more than a therapy failure. So we see improvement. It may be to a greater or lesser extent, depending on how advanced the Parkinson's symptoms are, or Parkinson's disease is. But if you fall in that window, we have every expectation it would work.
And do men and women tend to have different results with DBS? And if so, do we know why? No.
No.
No difference there. Okay.
No.
And
not to my knowledge.
Not to your knowledge. Well, I'm sure if it was, you would know. So not worried about that. This patient is asking about, and this may be specific, but they're asking about epilepsy. So I guess any other disorder and Parkinson's disease. Could DBS be set up to treat both issues? I guess my question would be more so, are there other disease modalities that would be an exclusion criteria for you to have DBS? Are there other things?
If you're too unhealthy to have surgery, so if you have a horrible cardiac history and your cardiologist says no, you can't have surgery, or you have some other disease state that would make you a poor surgical candidate overall, then that would be. I have done DBS with patients who have epilepsy. It's a higher risk because, of course, putting something into the brain can induce seizure. You can't treat epilepsy and Parkinson's with the same lead. There is deep brain stimulation for epilepsy and other disorders, but you cannot use the same lead or contact to do that. Patients who have diabetes are certainly at a higher risk for infection. So if you've had a kidney transplant or some other type of transplant and you're immunocompromised, then the infection risk can be higher, but there aren't disease states that absolutely preclude you.
Is there an age limit to DBS, having DBS?
We used to say there is, but now there's not. As long as you're healthy enough to have surgery. So I live in Boulder, Colorado, where 85 is like 55 or 65 everywhere else. I mean, they're hiking and they're biking and they're doing all of those things, which you should all be doing with Parkinson's, is exercise, because that works.
Yeah.
So no, if you're healthy enough to have surgery, we don't have any type of an age range or cutoff, at least in the United States.
Okay. And there's lots of questions about once you have the DBS in, are there things you have to look out for, such as, for instance, interference from the airport scanners or store exit scanners and high voltage power lines, anything that you have to kind of be careful of being in contact with?
Yes. So you will have to go through separate screening at the airport, and they always ask you if you have an implanted device, but that's not problematic. You do have to, there are reports of old style deep brain stimulation devices actually being shut off by store scanners. That's relatively rare. And they're few and far between, but that can occur. So I would recommend that anybody just carry their programmer with them. If your deep brain stimulation accidentally gets turned off for some reason, you know how to turn it back on, and you can turn it back on. You do have to, for instance, not be an electrician that works on electrical substations, or with large electrical devices like rewiring your washing machine, those kinds of things. No ultrasound, no massage, no acupuncture over the wires or the generators. You can dive up to 30 feet if you happen to be a diver, but the can has not been tested for greater than 30 atmospheres, or so 30 feet.
Right.
But you can still do those things. We typically say no roller coasters or other things that will whip your head around and break those wires. They are man-made, and they can break. So if you wreck your motorcycle, for instance, I've got a patient who rides his motorcycle. If you wreck your motorcycle and you break your shoulder, you're probably going to break my device. So those types of things. But in general, you typically go around and live your life. They are MRI compatible, most of them. But you have to make sure that it's on with very special settings, and the device has to be checked ahead of time and then checked afterwards, just to make sure that it is safe to perform an MRI. But most of the devices have either full MRI or MRI conditional approval.
Okay.
Every device is different, so.
Right. Well, that's good. And the roller coasters and motorcycle bikes, I think, would be no problem for me because I don't do that. This person wanted to know, are you a good candidate for DBS if you have a pacemaker and defibrillator? So other electrical devices.
You can have deep brain stimulation if you have a pacemaker or defibrillator. There are certain things the surgeon would have to do, such as send the generators to the opposite side or keep them a certain distance away from the other device that you may have. If your pacemaker is not MRI compatible, you can still do deep brain stimulation with a CT alone, although it can be a little bit less accurate because you can't actually see the structures you're trying to get to in the brain. So I would then, if you're doing deep brain stimulation with a pacemaker and it's not MRI compatible, I would recommend awake surgery so that you can actually test to see the structure.
There's a few patients or people listening have asked about candidacy for a DBS. One is asking about jaw tremor. Another is asking about speech and swallowing problems with regards to DBS. And do these improve, or do these are they unable to get DBS because of these symptoms? Do they come into play, I guess?
They don't keep you from having the surgery. Although if you have a lot of swallowing difficulty, then a surgeon may want to do a sleep deep brain stimulation just from a surgical safety standpoint for inside of surgery. And then jaw tremor may get better with deep brain stimulation. However, speech and swallowing difficulties don't get better.
Okay. And a lot of people want to know, how long is DBS effective?
So it's effective lifelong. It's not a cure for Parkinson's, but it will affect or treat the cardinal symptoms, the tremor, the stiffness, and the slowness. It will treat those things lifelong. However, as Parkinson's progresses, it may become slightly less effective. So if you're able to cut your medication, you may need to start adding medication in. But I will tell you that the oldest person I've ever changed a generator on was 102. She'd had her she was one of the first deep brain stimulation. It still worked for her. She was 102, and like I said, it's a very small surgical procedure, and she was still getting effect from her deep brain stimulation. And so we changed her generator because it was improving her quality of life.
That's impressive. To be 102 and be that active that you need, that's amazing. That's wonderful. There's also a lot of questions about coverage for this procedure, Medicare versus private insurance, and are there certain criteria that you have to fulfill before you can get it covered?
So it's FDA approved, and so it's approved by Medicare, and it's approved by all of the private insurance that I'm aware of. I've never had one be declined. Some of the private insurance will require a certain level of Parkinson's, meaning that United Parkinson's Disease Rating Scale, they'll require you to be so bad or have a certain score. And so I've had one patient who was tremor predominant, who didn't have a very high UPDRS score, and they made him wait, which frustrated the heck out of me, made him wait until he got what they considered was bad enough, which took a couple of years, and then we were able to implant. But I've only had one instance of that. Every other situation I've had no problem getting this approved in patients with Parkinson's.
Well, hopefully that'll change as more data comes out about the effectiveness of it early. That
Right.
A couple of people have asked about weight gain after DBS surgery. That's something I've heard of as well.
Yeah, so that can occur if you think about, so I'm a person who fidgets. If you could see me, I'm shaking my leg underneath the table right now, even though I'm staying still. That's burning calories, right? So any kind of motion or movement is burning calories. So is dyskinesia. So if you have a lot of tremor or you have a lot of dyskinesia, you're burning calories. If we then perform a procedure to take that motion or movement away, then you can in fact gain weight. So you have to watch your diet, and part of the deal is that if you get deep brain stimulation, you should then be better able to go out and exercise. So if you're exercising, if you are cycling, if you're doing your Tai Chi or your rock steady boxing, then you can counteract that weight gain.
Excellent. Yeah, that's important. And a lot of people with Parkinson's do have issues with weight loss or low weight because of a variety of issues. So it's interesting. A couple of people have also asked about speech problems after DBS, stuttering in particular. Is that an issue?
Stuttering doesn't tend to be, sometimes people can have some slurred speech. That's typically because of activating those motor fibers. So the side effect of stimulation. And so now that we have more directional leads and can be more precise with our programming, we can improve some of that. But sometimes you can have worsening speech, slurring, less so, at least in my experience, less so stuttering, but more sort of slurred speech. But now I'm really excited that we may be able to fix that, or at least decrease that if that's a problem for folks.
And so I think this might be one of our last questions, but if medication effectively addresses tremors, we still have significant rigidity issues. Are you still a good candidate for DBS? That's something.
Absolutely.
Yeah.
Absolutely. It works for, again, remember, tremor, rigidity, and bradykinesia, also known as slowness.
And does it help posture?
If you are moving more fluidly and better, it can help posture. Your muscles you're better able to stand up. It's not one that we would say, yes, your posture or that stooped gait is going to get better, right. But it certainly can. Anytime you're moving more fluidly, moving better, there's a chance that if you work on it with your physical therapist and with your big and loud therapy and with all of those things, that you can in fact stand up better, but it's not a claim that deep brain stimulation makes.
And there's one very last question, I think, and you don't have to talk about it very much, but people are asking about the ultrasound. Do you want to just maybe explain briefly what that is?
So focused ultrasound is a way to ablate or burn a hole in the part of the brain that controls this. So we used to do it with radiation. We called it a gamma knife or a cyber knife. Thalamotomy is the term that you might have heard. And what we do is we either take ultrasound or radiation and we burn a hole. Here's the analogy I use. Imagine you dig a hole in the ground. Now imagine for yourself that you want to move it 2 millimeters to the right. Good luck with that. Imagine that you dig a hole and you make it a little too big. Well, make that smaller. That doesn't happen. And so the advantage to deep brain stimulation over focused ultrasound or thalamotomies or what have you is that you really can change. It's reversible, which burning a hole is not, however you might create that hole. And then also it's customizable in the way that once you have a hole, you have a hole. That's the really basic, simple way to think about it. And so in my mind, folks who are great for thalamotomy or for ultrasound are people who are not surgical candidates. Okay. People who wouldn't do well with deep brain stimulation surgery. Maybe they are too sick. Maybe they have too many heart problems. Their doc says, nope, you're not having surgery no matter what. Then somebody might be a great candidate for those other technologies. I'm sure there are people who would argue with me, so that is my opinion, but.
Well, it's a knowledge-based opinion, that's for sure. So that's great. As our time comes to an end, I have one last question for you. For someone like myself, who may be at the point in their disease where they're thinking about a surgical intervention, what's the most important thing, the one most important thing we should consider when making that decision?
Really, it's your personal values and your goals.
Mm-hmm.
So if the therapy meets your goals, then it might be something you would consider. But deep brain stimulation is a very personal decision. It really is different for different people. Some people have no problem with it. Some people say, I'm just not having surgery. So I think it's really sitting down and saying, where do I sit with my therapy? What options do I have moving forward? Am I getting to a place where I'm falling outside of that window? Am I reaching a point where I don't have a lot of other medication options? Do I just need to, maybe I'm not on a ton of medication, but I just want to live better, and I don't want anybody to see my dyskinesias. I don't want anybody to see my tremor. It's such a personal decision that it's really sitting down with yourself and your care partner and your family and your provider, your neurologist, and possibly a neurosurgeon, and just deciding for you if it meets what you value and what you need out of your therapy. And that's that. I can't emphasize that more. Goal attainment and really understanding your own values is the most important.
I'd like to thank everyone for joining us today, and especially Dr. Beasley for spending so much time and giving really great advice to all of us. And David Phinney has said, since his diagnosis of Parkinson's disease, he's learned to redefine victory. And I want to challenge all our viewers today to redefine your victory, to take control of those variables that you have control over, be a part of your management decisions, educate yourself, empower yourself, and live your best life. So till we meet again.
Thank you so much.
Thank you, everybody.
Take care. Bye-bye.